doing a shunt, and I'm seeing some patients, and we're gonna have a great time. Man, look at all these thank yous. Yeah, we all thank Dr. Bavard a lot for being able to pop in. You know, that's obviously a ton of very cool, very innovative stuff. I don't think you guys realize this hasn't really been seen anywhere. You guys are kind of the first people to see it. You know, that clinical trial for the mental flap is brand new. There's only been a handful of patients enrolled in it so far. And it's really a last ditch effort for people who are really, really sick and don't have many options available. And so it's a complex surgery without a doubt. You know, it requires multiple teams. It requires a general surgeon, an ear, nose, and throat doctor for the facial part of it, a neurosurgeon for the tumor resection, a vascular neurosurgeon to sew vessels together. And so it's truly a team effort, and it's a big effort. And we'll know, you know, in a couple months the benefits, and then we'll be able to talk more about it. So we'll let you guys know. You guys will be the first to know probably then too. What else do we have? Let's see. Other questions real quick before we dive into the next session.
Do you know what makes someone a good candidate, like for this clinical trial, Dr. D'Amico?
For this clinical trial in general, you have to have a recurrent brain tumor that's not responsive to chemotherapy. And unfortunately, you have to have no options available for you. And so in general, you need to be, what we look at something called a Karnofsky performance status. You have to be well enough to have a surgery. You have to be well enough to undergo chemotherapy, right? And so these are generally people who are not the sickest of the sick, but their options are limited and they're progressing rapidly, right? They look at things like, you know, if you've had multiple abdominal surgeries, maybe you're going to be very high risk, right? For the abdominal portion of the surgery. You have to have good liver enzymes, kidney function. You have to be able to tolerate chemotherapy. You have to have support systems. And so that's kind of also why I think the Hawthorne effect is such a big thing, where people who are enrolled in clinical trials are typically the people who are not as sick as the people who have really no options available to them, right? And so they do better.
Is this surgery done in tandem with like what Dr. Langer would do with the microcatheter? Like, is that how they end up delivering it, or is that a separate thing?
No, not yet. And so this is, you know, research is iterative, right? Meaning that we take small steps as we go through this and we figure out what works and what doesn't work, right? And so right now, you know, we were talking about it before, John obviously interested in bypassing the blood-brain barrier, whether it's with a catheter and a blood vessel, whether it's a temporoparietal fascial flap where you're bringing in new blood vessels, or now where you're taking momentum, which is even more blood vessels, grows fast and has immune cells associated with it, right? Those are kind of the initial first steps. Down the road, could you, since this is grafted into an artery, get evidence that the omental flap is adhering, is providing increased blood flow, is providing good immunogenic effects, and then put a catheter up there and target that specifically? Absolutely. But that's a couple, you know, probably years away, right? We need to figure out the first steps first. Is it safe? Does it work, right? Step number one, can you do it, right? And so far the results I think are positive, but it's very, very early. This is like I said, this is brand new. And so you guys are getting a real treat by seeing it. The part about chemotherapy affecting other parts of the brain. So this is the interesting thing, right? So when you have a blood-brain barrier, the blood-brain barrier protects the other parts of the brain, unless you're using a chemotherapy that passes it, right? And so in general, the blood-brain barrier does have this dual effect, but we need to figure out how to get it into the tumor because it's also unfortunately restricting chemotherapy to the tumor. So let's see, just any other things. Graft rejection, not really, it's your own body. Post-op care. So post-op care is the same as any craniotomy procedure, right? You go to the ICU, you're observed overnight, you're kept on steroids and anti-seizure medication, because with GBM, it's an intrinsic brain tumor, which means you're more at risk of having a seizure, right? They spend about a day or so in the ICU, depending on how they're doing. They get an MRI to take a look, make sure there's no problems. Then they start walking around and they go home. You start chemotherapy and radiation depending about 4 weeks after, 4 to 6. You need everything to heal, right? Radiation is going to affect the healing. Chemotherapy can actually affect the healing as well, because you need an immune system to heal. There's no restriction of the blood vessels that are growing to the tumor microenvironment. The tumor microenvironment is the brain. So as far as those vessels will go, presumably as far as your chemotherapy will go. You know, there are different tricks to bypassing the blood-brain barrier. People have tried different things. Intra-arterial chemotherapy is really one of John's innovations, where he uses something called mannitol. And there's different drugs too. that go in and they open up the tight junctions on the endothelial cells and allow chemotherapy to pass through. That's a targeted system, but it affects everything within that arterial tree, right? The arteries supply an entire region, all right? Temporal parietal fascial flap is putting something on the brain itself, hoping that the blood vessels will go in and those won't have a blood-brain barrier, in which case the drug can go in through that way, through systemic circulation, right? There's something called convection enhanced delivery, which I used to do work on, which is where we put a catheter in the brain into that, surrounding tumor tissue, and we actually pump chemotherapy into the brain itself. And that's not restricted to any vascular supply. It's restricted by how much volume you can get in the brain tissue and how the patients tolerate it. There are new techniques called focused ultrasound, which sits outside of your head, and it actually blasts little ultrasound in there to open the endothelial cells, which will allow chemotherapy, and that can be targeted to specific areas. And so this is a hot topic without a doubt. People are very, very interested in it. You have to remember that the tumor itself, the blood-brain barrier within the tumor is actually disrupted, right? The way a glioblastoma works is it causes something called microvascular proliferation. Cells grow like crazy and they're very disorganized. It's not the tumor that you care about, right? Because also we're going to do surgery, we're going to remove as much of that as possible. It's the infiltration zone, right? It's the tumor that goes out into the tissue, right? And so the reason that's important, the analogy I always use is it's a bowl of spaghetti and meatballs, right? With tomato sauce. You can remove your meatballs, all right? But imagine trying to remove the spaghetti sauce off of every piece of spaghetti. It's impossible, right? So what you want is you want a wash. You want something that can go through outside of that, outside of what you can do with your hands and kind of get rid of all this tomato sauce. It's nearing lunchtime, so. All right. So yeah, I saw a number of people ask about controls for trials. So you have to think about what kind of trials you're doing, right? There's different stages of clinical trials. There's, there's stage 1, there's stage 2, there's stage 3, there's stage 4. And so you don't always have to have a randomized placebo-controlled trial. Sometimes what you can do is do initial safety and efficacy trials. And a stage 2 trial is really an efficacy trial and see, is this really helping? All right. And what you do is you compare that to historic controls and you try to case control them. You try to make them as similar as possible. So in this case, we would not do a placebo. If we were going to go to a stage 4, like a bigger trial that's placebo controlled and randomized, then patients would get randomized into some sort of sham surgery procedure, just to see, because maybe it's just the surgery that's helping, right? Maybe it's just cutting the skin that creates an immune response.
Dr. D'Amico?
Yeah.
I have a question. So this might be like, I don't know, too niche, but like if the tumor disrupted neurologic function, like once it's removed, is there a way to like reverse that disrupted function? Like will the function ever come back, or is it kind of just like once it's gone, it's gone?
Yeah, it's a really good question. So gliomas, right? And I've seen a number of people responding to a number of people. Gliomas are tumors that originate within the brain, right? They are a primary brain tumor. It means some cell in the brain goes haywire and it forms a tumor, right? And these exist along grades, right? There's grades 1, 2, 3, and 4. Grade 1s are benign, you can remove. A glioblastoma is a tumor that it grows so fast that it actually kills the middle of itself because it exhausts its blood supply as it's growing, right? And so that central part is all necrosis. But the cells as they infiltrate and as it becomes all tumor, that brain dies. In a glioblastoma, because of the speed in which it grows, the brain that is injured really doesn't come back, all right? And that's non-functioning brain also, but it's dead. And so you can remove the entire contrast-enhancing boundary of a glioblastoma and sometimes more and preserve function that exists when they go to the operating room. If someone already has a deficit, there's a very good chance if it's caused by destruction of the tumor, it's not going to come back. If it's caused by pushing of the tumor or swelling around the tumor, then you can get that back, all right? Now with a lower grade glioma, these cells actually are just infiltrative and there's working brain within the tumor. And so in the lower grade glioma, such as the one that Dr. Ellis is doing upstairs, you care about function immensely, right? Because what you don't want to do, and studies have shown this, is you don't want to hurt people. And so we talk about safe maximal resection, all right? And so you do monitoring of all the nerves and the neurologic function and language, and you stop the surgery if you're going to get into those areas. And that's because the prognosis, the growth rate of those tumors is so much slower that, number one, patients need to be able to speak and move their body to do treatment. And number two, the brain has more time to reorganize function. All right. And so there are certain functions that will not reorganize, right? Motor control is really not going to reorganize. That's if you remove the motor strip, that's it, you're done. But things like higher order thinking, things like language can reorganize a bit. All right. And so in the lower grade tumors, we really, really care about that function. In a glioblastoma, like I said, if it's function that's injured because of pressure, mass effect, swelling, we can get it back. If it's because the tumor eroded it, if you presented with that symptom, it's very, very difficult to get that back. It probably won't come back. All right.
Got it.
Someone just asked the point to stop removing the tumor. And this is a good way to loop back into the 5-ALA talk, right? So when we look at an MRI, right, we look at a two-dimensional image and we see a contrast enhancing boundary within the brain. And studies have shown that if you remove that contrast enhancing boundary, you're going to improve survival. All right. And so what about the tumor cells that go beyond it, right? And that's where it's very, very difficult to know where to stop. Even in the operating room, glioma looks like regular brain. And so there is a gliotic boundary. The tumor creates an inflammatory response and recruits microglia that all come to the outside, the leading edge of it, basically. And there's typically a plane between normal brain and tumor that you can kind of manipulate and take advantage of and remove. Now, you confirm that with your navigation in the operating room. Remember, we're using a GPS system for the brain, where right before the surgery, we register the brain to the MRI. And I have a special wand in the OR where I can touch parts of the brain and know exactly where we are with millimeter accuracy. So you remove what you believe is tumor, you check your navigation system. Well, that was great that was game changing for 20 years or so. And now we have 5-ALA or fluorescein in some places. 5-ALA is this drink that John alluded to. It's actually a prodrug. You drink it, it's metabolized in the tumor cells into a fluorescent molecule called protoporphyrin 9 that lingers in those cells. When we turn on the fluorescent light, we excite the fluorescent molecules, and they glow. It glows pink. Studies have shown that pink color actually extends beyond the contrast enhancing boundary. So you're actually able to get a supramaximal resection. And there's really good data coming out now that supramaximal resection is better for overall prognosis in glioma. And so you could take that one step further. If you have a tumor in a pole, maybe a frontal pole, an area that you can remove safely, the right frontal lobe, the right temporal tip, these are like prime areas, you can do actually a full lobectomy in those areas, remove greater than that 2 centimeter margin. So you're getting the majority of infiltrative cells, and you can actually extend prognosis really, really significantly longer. Now, you wanted to ask, why not just remove half the brain, right, and let people live? Unfortunately, there were studies done in like the 50s and 60s that at the time of diagnosis, tumor cells, even though the majority are within that 2 centimeter margin, there are tumor cells throughout your brain. And so they follow the white matter tracks, and they're everywhere. They're on both sides. And so it might be a slow cell that's taking a really long time to grow, but it's a tumor cell and it's there. And that's why surgery will never be the cure for this disease, right? Surgery will help. Surgery gets you tissue, surgery decompresses, but it can't cure. You need chemotherapy. You need something that can wash the entire brain clean. The other thing about GBMs that you have to remember is GBMs, we ad nauseum, we use the term heterogeneous. A GBM is not a clonal representation of a cell like other cancers, right? Other cancers is one cell makes clones of itself on itself, and it just grows and grows and grows and grows as a ball. A GBM creates a tumor microenvironment, and it recruits other cells into it. So it's an astrocyte, it's a microglia, right? It's a neuron that changes. And so you have different cell types that are all rapidly reproducing themselves. And in addition to that, accumulating genetic changes. And when you get these mutations, they are escape mechanisms potentially, right? And so when you treat a tumor with a cancer, you may only treat a certain portion of that tumor. There may be cells that have escape mechanisms that have developed that allow them to bypass your chemotherapy, and that's why they recur. And so, it's an extremely it's a moving target, right? You're trying to constantly battle a moving target. And unfortunately, the brain is, an 8-pound lump or so on the top of your head, and it's restricted. You can't keep going taking it out. All right. And so you have to chase these tumor cells down. And so, this is why we kind of slow and steady work towards treating these things.
Have you used 5-ALA in spinal tumors too, Dr. D'Amico?
I have. Yeah, I showed it the other day in that neuro-oncology thing. Yeah. And so any tumor that metabolizes, well, listen, so 5-ALA is a prodrug. It's part of the heme pathway, right? Because anyone who knows what the heme pathway is, heme is how we make blood cells, right? And so the heme pathway exists in every cell in the body. It's just so that tumor cells and glioblastoma and then other types of tumor cells have a disrupted heme pathway, and they actually retain the metabolite. It doesn't get converted into the byproducts, the normal byproducts. And so you can use it in any tumor cell. The question is actually metabolism. It's how fast that tumor cell is metabolizing this stuff and how fast it washes away. So 5-ALA washes away from normal cells very, very quickly, metabolize very, very quickly. Then the tumor cell lingers, and it's not forever. It lingers for a certain amount of time, right? The same thing with fluorescein. When would you need to use 5-ALA? You never need to use 5-ALA. But I think it's a game changer in certain situations without a doubt. In fact, 5-ALA can hurt you sometimes. If you're in an eloquent region and someone has good function and the 5-ALA is glowing pink and you remove it, you may injure someone. And so you really need good training. This isn't like a paint by numbers. The picture is going to look beautiful every time. It's an adjunct. It's a helper, right? It's an insurance policy. You can take out the way I use 5-ALA personally is I actually do the surgery the way I was taught how to do the surgery. And then at the end, I turn it on and I see did I miss any areas, right? Because there are sometimes areas that are easy to miss, right? When you're looking into a cavity, the layer that's right underneath the lip, right above you, you can miss, right? You're focused so much at the depth of the other areas, you sometimes miss looking backwards. And so those are key areas, or the depth. There's sometimes when you're near very important structures, you can turn it on. And so it is not an answer. It's something that you use to help you with your decision making. All right. But anyway, look, that was great. I really appreciate John coming by. It's always a pleasure to have him. And it's great to also talk about kind of the very interesting stuff we're doing here at Lennox. And I think there's big things to come, without a doubt. And so let's see, a few housekeeping things. How's Brain Turns going? Can we light up the chat? Are people having fun? Do we enjoy this? All right, great.
Nice, I saw like see.
That's very nice. How's Ashley doing? Can we get a little Ashley love?
Oh my gosh.
I think she's doing a great job.
Oh,
I think she's
thanks,
you're keeping conversations going. You're very engaged. I love it. I think it's a great thing. And it's great to have someone, I think, that bridges the gap between where we are in our careers and where some of our students are in their careers, right? Because you, believe it or not, have your own insight to offer this group just about how things are going. So. You can tell everyone what it's like to live in a 400 square foot Manhattan apartment.
It's a 100 square foot apartment, Dr. D'Amico. It's literally 100 square feet. I got a portable AC thing that was supposed to cool down a 250 square foot apartment. And my dad was like, that's too big. You don't need that. And I was like, awesome. I have a question about glioblastoma, about the resection. Can I still ask it, Dr. D'Amico?
Yeah. I mean, we're still rolling.
We're still rolling. Okay, cool. Thank you for the love, everybody. I appreciate it. So I was seeing a resection of glioblastoma the other day, and they at one point wanted to use an ultrasound. The probe was not thin enough, so it didn't work out. But do you know why they would use ultrasound? What are they looking for? Do you know?
Let me see if I can find this slide. I have a slide about things that we use in the OR. And yes, I do know why. Believe it or not, I know why.
That'd be awkward if you're like, no clue, sorry. This is
no
what
idea.
I do,
Doesn't make any sense. No, bananas. Hold on, let me find my presentations. Presentations. This one. All right, I'm going to share real quick. Wait for it. And then I'm going to show you guys a surgery. Believe it or not. All right, does everyone see my screen? You guys see a PowerPoint? This is a talk I gave. This is me, by the way, when I clean my hair up and I shave and I don't have a new baby puking on me. Amy and I gave a talk to a cancer support group about the side effects of GBM. Just so everyone knows, I know a lot of people didn't know this. Glioblastoma is a primary tumor from the nervous system. We talked about this. About 24,000 new brain tumors annually in the US. It's not a lot, right? This is a rare thing, right? If you think about it, there's 8 million people behind me in New York City, right? So 24,000 brain tumors annually in the entire country, not a lot, but 40% of those are GBMs, all right? And so that's a critical thing. This is what they look like on an MRI. This is that contrast enhancing rim we were talking about, right? Where the tumor has a lot of contrast. And this is what they look like when they meet me. I remove them. We talked a little about this. Let me get to the slide that I want to tell you about. So this is it. So how do we get safe maximal resection? All right. And there are a lot of techniques. All right. And so we talked about 5-ALA, right? That's this, right? Where you have tumor tissue and you see like, oh, so like, yeah, that's discolored, but like, how do I really tell the difference between that and this, which may be perfectly functional brain, right? And so we light up the 5-ALA and it kind of reaffirms us. And this is just on the surface. When you get under the surface, it actually gets a little better and brighter. This is our standard navigation system. So the way this works is you put an MRI, a thin cut MRI, 1 millimeter cuts into the machine. You pin the head and you rigidly immobilize it. And you put a tracker, all right? And you basically, there's a camera system on here, this thing, that visualizes the tracker. You trace the bony prominences of the skull, all right? Relative with markers, relative to that tracker. And the machine puts it together, right? And it's able to say, basically exactly where everything is. Give me 1 sec. I think my kid's singing a lot. Hey, bud, can you sing a little less? Just like a little lower. So, sorry, he's okay now. So anyway, this allows us with millimeter accuracy. Once the patient is draped, we rely on that tracker. We know where everything was distance-wise from that tracker. And so we know exactly where we are with millimeter accuracy. The problem with the navigation system, as you can imagine, is the minute we take the skull off, we release some of the cerebrospinal fluid or remove some of the tumor. Do you think the brain's in the same exact place it was when they got their MRI? No way, right? It's mobile. It sits in fluid. It's like a thing shaking around in a water balloon. So you run into problems with something called brain shift, right? And all of a sudden your navigation can be off. Even though it's on the skull, it's fine. Where it is in the brain is totally wrong, all right? And so limitations. This is an intraoperative MRI machine. An intraoperative MRI machine is, some places that have massive ORs put this in. Basically, you take out your tumor, and rather than leaving the operating room, you put a cover on their head and you send them into an MRI. It tells you where there's more. Then you re-register to the brain lab and you go back in and you take out more. The problem with this is it costs a lot of money to put an MRI machine in your operating room. And it adds about an hour to your surgery, right? So the patient's head is open for an extra hour, increasing risk of, surgeon fatigue, things like infection. Hey, bud, let's turn it from 11 to like 6. All right.
I asked about your work-life balance, so.
You want to come over here and see what's going on? You want to come sit? Come here, you can sit for a minute. Now down here in the bottom left, this is the ultrasound, all right? And what you can see is this doesn't come exactly to the surface, right? Come around the other side, and so when you're looking through normal brain again, you want to make sure you're exactly where you say you are. All right, good job. You gotta be quiet though, okay? Daddy's talking. Sit like a good boy. Sit like a good boy. This is like when you did Zoom school. All right, good. So anyway, so when it doesn't come to the surface, you can put the ultrasound right on the brain surface and you can see with some granularity, not a lot, where the cysts are in relation to the solid tumor. And you can actually see the cellularity, see how thick, how white this is versus down here. It's called hyperechoic, right? And so the problem with it is that it's not as granular. You can't see individual cells. You can't see what you're taking out as well, but it is extremely helpful, all right? And so that's why someone would put an ultrasound down to make sure they didn't leave a big chunk of easy to see tumor. Watch your head, bud. Good job. Down to the bottom right is how we do awake craniotomies. So this is called an Ogeman stimulator. And in this, what we've done is they've labeled functional areas of the brain that they identified through stimulation with electrical stimulation. And this is what they're doing upstairs at Lennox, not here. This is my home. But yeah, so what they do is they have the patient awake and they tell her to talk and they stimulate areas of the brain. And when the talking gets disrupted, they know that that's a language area. Or when she's unable to do repetitive movements with her hands or open and close, that's a motor area, right? And so this is what I love. I love this part of brain surgery. I think it's incredibly interesting. It's a unique thing that no other surgical subspecialties get to do. It's to wake up a patient in the middle of the operation. It's kind of unreal, right? And what we do is we isolate, we identify our functional boundaries that we will not cross, because again, the idea is safe, maximal resection. All right, so we take out as much as we can safely. A neurologic deficit limits the ability to get chemotherapy, and it limits survival. And so you can't do that with people. But anyway, that's my spiel on operative adjuncts. And so that's why an ultrasound was used. That's a very long answer to that, Ashley.
Thank you.
Let me get back to Zoom. I'm going to stop sharing for a minute. So anyway, guys, it's 10:58. Let's jump. We're supposed to do the research one after this one. We kind of reversed the order a little bit. John gave us a little bit of a research highlight as well as some operative videos. I'm going to show you. I'm going to change the plot, I guess, a little bit. The plot twist. I don't know. How do we want to say this? I'm going to change the narrative. That's what kids say nowadays. We're going to change our narrative. So we're going to talk about different types of tumors for a minute. And so it's a neuro-oncology conference. And so, it's obviously going to be a tumor, but I want you guys to think. I want it to be interactive as well. I can see the chat. So the case I'm going to talk to you about, again, very, very different kind of scenario here. It's a 41-year-old guy who presented with headaches and initially to his primary care doctor, and maybe some kind of what he said was worsening vision. All right. And he couldn't really describe it to his primary care doctor. And so, how common do we think headaches are when people come to the doctor? Very, yeah, light it up. Exactly. And so extremely common. And so what do you think, kind of similar to our back pain talk the other day, what do you think doctors initially do when someone has a headache? All right, a neurologic exam. I like that. And why is that brain CT? People are jumping straight to MRIs. Aspirin. Well, so I think a lot of this stuff is right. So number one, you get a history, right? So someone comes in and they say you have a headache, and you get a history. You see the patient, right? And part of your history includes an exam, right? And so let's say the guy didn't have any kind of weird vision findings. It was just headache. Then a lot of the stuff you guys are talking about makes sense, right? Try over-the-counter pain medications. How, you want to find out how often your headache is and see if there's triggers to it. Could it be a migraine? Maybe you see a neurologist, right? But it's such a common thing, and it's such a, there's so many causes of headaches that it's sometimes a difficult thing to pin down exactly what's causing it. Now, this doctor did a great exam, all right, especially because of the vision findings, and found out that actually this guy, aside from having constant headaches that were not remitting, he was having difficulty seeing out here, kind of where my hands are, way out far, all right? And in fact, he would kind of like walk into door jams when he was walking through doors and stuff like that. And driving, he just felt a little bit more uncomfortable. So does anyone know what that's called when you lose kind of way outside of your vision like this? Yeah, Fatima just nailed it. Yeah, both are good. Jack Howard also. Bitemporal hemianopsia, right? And so he did an exam and he noticed that the guy did have loss of peripheral vision. And so, chronic headache with a loss of peripheral vision, that's a red flag, all right? That's not your normal, oh, I see, spots and I go lay down in a dark room. That sounds more like a migraine. Or, once a month, my eyes water, it happens after I drink red wine. That sounds more like a cluster headache kind of picture, right? There are some of these key kind of like scripts that we hear. But when you have bitemporal hemianopsia that's reproducible on a physical exam plus a constant headache, you start to get a little bit worried, right? So we sent the patient for, I believe he got an MRI at first. All right. And so when we're, being neurologists, because to be a good neurosurgeon, you have to be a neurologist first. The most important thing is, where do we localize a lesion to? All right. So something that can cause a bitemporal hemianopsia, where do we localize that to? So an occipital lobe can cause a unilateral hemianopsia, all right, or an ipsilateral, I guess. Optic chiasm is a great choice, and I see a lot of people. Optic nerve would cause one eye monocular issues, right? So proximal to the chiasm, you have your nerves, right? And you can get monocular anopsia, basically hemianopsia, but it would be monocular if it's only the nerve. Once you get to the chiasm, now you have crisscrossing, right, of all the fibers, and they go to the tracts. If you get a tract, now you're getting binocular issues, but usually it's a hemianopsia. It's an ipsilateral hemianopsia, not a bitemporal, right? And there's diagrams for this. I apologize, I don't have them. But anyway, so we sent this guy to wait, hold on, I have to see if I can find it. All right, I'm gonna start sharing my screen again. So we got this guy an MRI, and based on the MRI findings, he was sent to me, all right? All right, can everyone see my screen? Ashley, you got it? All right, sorry, I had to reload the chat. So let's take a look at this real quick. This is, what image are we looking at? I mean, I told you it's an MRI, but what's special about this MRI? Anyone? No one? Yeah, it's got contrast. All right, good. And there is a mass. Good, pituitary lesion, I'm seeing good. Let's start with the simple. Don't jump the gun here, guys. Let's go slow. It's only a 3-minute video. So yeah, so this is a contrast enhanced T1 MRI or T1 weighted image. And this is a coronal and this is a sagittal, right? And this is the way I describe these to patients is this is basically a mirror, all right? The patient here is looking at us. And so the right side of the patient is over here. Sorry, I think my chat's covering it. This is the right side of the patient. This is the left side of the patient, all right? Then on the sagittal, this is his nose and the nasopharynx, the oropharynx here, all right? This is the back of his head over here. And this is a cut through the middle of his body. Remember, Sagittarius is an archer, right? So it's the archer from the side. You're looking kind of from the side to see that. And coronal is kind of like cutting through a crown, all right? So things that we can see, right? So this is the cerebral hemisphere. This is the temporal lobe. This is the sylvian fissure, okay? This is the sylvian fissure, all right, going up. This is the ventricular system. These are the lateral ventricles, all right? What is this little U-shaped structure right here, you think? Ashley, can you just holler stuff out so I don't have to block everything with the chat?
Someone said hypothalamus. I think it's the corpus callosum though, right? Or am I wrong?
No, you guys are getting close.
We're wrong.
So corpus callosum is here. Hypothalamus surrounds the third ventricle, that's here.
Compressed
chiasm. There you go. That's the optic chiasm right there. This little light gray structure. And it should be a straight line. And you can see that it's bowed over the top of whatever this thing is that's being measured. This is a classic radiographic sign. It's the measurement sign. It means someone saw it and measured it for us. All right. Now, when we get to the skull base, we want to think about skull base anatomy, right? And so what we look at here are some of the holes, right? So this is actually probably foraminal valley here. What's this black dot? No, black
optic
dot
canal,
is not the optic,
vertebral artery, optic nerve.
It's an artery, I'll give you that.
Air.
Not air. Not ACA.
Interior cerebral artery. Interior cerebral artery.
It's the internal carotid. Yeah, ICA
internal
is correct,
carotid,
right? And the internal carotid in this area, there's segments to it. I don't know if anyone's gone through it. There's a bunch of segments as it comes up through the neck. And this is the cavernous sinus section, which means that it's called the carotid siphon. Carotid artery goes into the cavernous sinus, which is 2 leaves of dura that contain venous blood, and it creates an S. It comes towards us first, it goes towards the front of the head, and then it goes up. Give me 1 second, guys. This is calling twice. Hold on a sec. Let me just take this. Hello? What's up?
You're not on mute. You're not on mute, Dr. D'Amico, if you want to be.
Yeah. Mm-hmm. Yeah, what's on Tuesday right now? Perfect. Put them on Tuesday. Okay, sounds good. Even better. And if he wants, he can pop in on Monday to talk. Okay. Do it up. Thanks. Bet. Sorry, guys, just booking surgery, saving lives. Anyway, okay. So carotid artery sits in the cavernous sinus. Cavernous sinus is venous blood. What else is in the cavernous sinus? Does anyone remember their cavernous anatomy? Cool stuff. I'll take that. Fatima's killing it right now. Fatima, are you a neurosurgeon? Is that what's going on here? Cranial nerve, Bahi, you got it too. Exactly. Optic nerve is not in the cavernous sinus. So medical student, I love it. So yeah, the cavernous sinus exactly has exactly the nerves that she mentioned in the chat. Did everyone see what they were? So it's 3, 4, 5A, and 6. Well, basically 3, 4, 6, and a little bit of the 5th nerve. And so these nerves actually come off the brainstem and they go into the cavernous sinus and they flow in there. And 3 and 4 and 5, V1 basically, are in the lateral kind of aspect of it. And then the 6th nerve floats right around the carotid artery, right in the middle of it. And so, yeah, now we got people throwing it in there. Good job. And so this in between the cavernous sinus is the sella turcica, which people were mentioning before, right? And again, let's go to the sagittal and kind of reorient ourselves here. Remember, again, frontal lobe here. This is the ventricular system. This is the corpus callosum, which we talked about, right? This is the sella turcica, which is expanded. It's not normally this big, all right? The chiasm here is on top of the tumor, all right? And the chiasm, you have to remember, has a clear piece of tissue that's called the lamina terminalis. That's the floor of the 3rd ventricle, right? So it's all kind of connected. This is the prepontine cistern. This is the pons, the midbrain, the medulla down here, all right? And there's cranial nerves floating in through here, all right? And so the sella turcica is Turkish saddle, right? That's what it means. And so it looks like a saddle for a horse. And the pituitary gland normally sits in there, all right? And this is not a normal pituitary, right? This is a enlarged sella with a large contrast enhancing lesion within it, all right? And so this is concerning for something called a, what? Anyway, I think is my chat working? Am I frozen? Oh, adenoma. All right, I like it, yeah. And specifically a macroadenoma, right? Microadenomas are below a centimeter, just traditionally. Macroadenoma is something above a centimeter, okay? And this is a macroadenoma without a doubt. Now, can we jump the gun and say this is definitively an adenoma, or is it something else, right? And anytime we're looking at something on an MRI, right, how do we really know what that is, right? You need tissue to be able to check, right? And so we have a differential diagnosis. So pituitary macroadenoma is without a doubt the first thing on the differential. But what else? I see a craniopharyngioma. I love that. What else could be over there? We already said macroadenoma. So there's inflammatory conditions. Hypophysitis, sarcoidosis can look like this. Not so much, but it could. Meningiomas can look like this. Hypothalamic tumors can extend down to something called a hamartoma. This is a suprasellar tumor, and there are a lot of things that can show up there. Craniopharyngiomas, terrible teratomas. There's an entire bunch of optic nerve gliomas can look like this. Aneurysms can look like this. You want to make sure it's not an aneurysm, because if you biopsy an aneurysm, you're going to be in a world of hurt. All right, and so there's you always get your differential, and then you start working on how do you figure out what this is, right? And so someone said hormonal check, and that's actually a great idea. And so what hormones does the pituitary gland make? Prolactin, testosterone, tons is a great answer. ACTH, all these, yes, growth hormone, exactly. And so we send a hormone panel and we check the levels, all right? And in general, the most common thing is a benign macroadenoma, meaning it's not actually a secreting tumor. What it does, though, is it does create a hormonal level abnormality. Does anyone know what hormone gets abnormal just from having a tumor in the sella pushing on the pituitary gland? Prolactin, that's right. Most commonly prolactin. And it's called stalk effect. And when you push on the normal gland, the prolactin level elevates. And it elevates to a degree that's not as high as if you actually have a prolactin secreting tumor, in which case it goes sky high, all right? Any of these other hormones, though, can have their own adenoma cells, their own secretory cells that send your levels to the roof. And as a result, patients present with a huge kind of plethora of symptoms, right? You can end up with things like temperature control issues, always feeling hot and cold if your thyroid's all screwed up, right? Prolactin can cause it can cause lactation, it can cause amenorrhea, all right? You can have issues with your hands growing too big, you're changing ring sizes, your hat sizes, with things like growth hormone secreting tumors, right? Andre the Giant was a acromegalic, right? Acromegalics are extremely sick people. You can get a Cushing's disease, which is a cortisol secreting tumor, right? And so there are different types of symptoms you can get from this. And depending on what your tumors secrete, there are actually drugs that can treat some of them. So for prolactin secreting tumors, we can treat with cabergoline, which is actually will shrink the tumor without any surgery, right? And so we checked this guy's labs, and all his labs are normal. His prolactin's elevated. It's something like 20 or 25, something mildly elevated. So it's probably stalk effect. Now, this is a young guy with a large tumor with visual field symptoms, all right? And so what do we do for him? I like transnasal approach, but surgery is the right answer here because he's symptomatic, right? Some people would try medication because actually some percentage of these tumors do have dopamine receptors on them. And you can sometimes get away with it, but in general, this is a very good surgical case. And so I'm gonna show you that. And so this is the case. Can you guys all still see my screen? Good. I'm gonna pause it. So we're going endonasal here. All right. We do this with our ENT colleagues, okay? And we're going in with an endoscope through the right nostril. Typically, we're going to use both nostrils though, okay? And you're going to get to watch the whole thing. And so I can't see the chat again. So Ashley, if you're getting good questions or whatever, just jump in. All right. But we're in the right nostril here, and this is one of our ear, nose, and throat doctors. And what you see is we start with removing the middle turbinate here, and that's going to increase our pathway. Okay. We're also going to remove mucosa. Mucosa is very vascular and it grows back very, very quickly. So we can actually remove a good portion of it. And these are all done with a tiny endoscope. So just in the nostril, there's no real incision here. And so here we are removing the mucosa off that turbinate. All right. Obviously, now this is a suction Bovi. This is an instrument that it's cautery and it's also able to suck smoke away. And here we're at the floor or the entryway to the sphenoid sinus. And so basically we come in this way, all right? And there's mucosa here, okay? And this is what they're cauterizing right now, all right? This is the sphenoid sinus, which is an air cell. And then we'll get to the floor of the cella, okay? Let me get back to where we were. All right, and so it's sped up a lot, but you'll see that we're gonna cauterize that mucosa here, all right? And then we're exposing, this is bone in the background here, all right? And so cautery. They use an instrument to basically push the mucosa, around and separate it. All right. And now what you'll see here is this is the bone of the sphenoid sinus, right? And so at this point, you drill that away. All right. And you can see it's starting to drill. And here we're coming bilaterally now. So here, the vomer, which is a bone at the front of the entry, the rostrum of the sphenoid sinus, has been drilled away. We have access from both nostrils coming in here. And this is the floor of the cella. These are bony septations, which basically keep the cellar, the sphenoid sinus open for the most part. And those all have to be drilled flush. So you see the curvature of the cella itself, all right? So here we are, drill. Drilling down that septum very, very fast. Try to get a good view for you before we go in. All right, so this is a good view. So now this is the floor of the cella. All right, the entire rostrum of the sphenoid has been taken away. All right, vomer's gone. We have access from both nostrils. Okay, here's that septum that was there that's been drilled fully flush now. All right, and so right beyond this is going to be the dura of the cella, and beyond that will be the pituitary gland. Okay, what he's showing you here is where that septum went. All right. Now, typically those septums grow towards something that's very important that's lateral to the cella. So what did we say on the MRI is lateral to the cella? That's really important. Ashley, give me some answers.
Nothing yet. ICA, carotid, internal carotid.
Yeah.
Cavernous.
Well, where's the cavernous sinus, that's exactly right. And so the carotid is in there. And actually you can open this window endonasally enough that you can get to where the optic canal is up here and the carotid artery is over here, all right? And you can find there's a little window there. And so mucosa removal, here's drilling now of the floor of the cella, all right? And so what you see behind this is a diamond tip drill, all right? And the floor, that's dura there that covers the cella, okay? So the bone's gonna come around, it's gonna expose the whole thing here. All right, you can see how that's soft tissue behind there as the bone comes up and around, okay? And we're exposing it nice and wide all the way out to the cavernous sinus bilaterally. And these diamond tip drills are really important because they actually won't injure, as long as you're perpendicular and you're gentle, they won't injure soft tissue. They'll just take down the bone. But I wouldn't push it in there, just gentle. It is neurosurgery. All right, so we've opened up the full cella now with the bone, all right? And you can see that soft tissue there. So now what this is a Doppler. And what we're saying is, are we far enough wide? Can we hear the cavernous sinus? Can we hear the carotid artery, right? And the Doppler is an ultrasound, right? And so I unfortunately don't have sound, but what you would hear is this whooshing sound of the Doppler going. All right, same thing on the other side. And I'll show you now with the scan, I believe. Let me see if I move this. So this is exactly where we are, okay? See that, let me go back to the Doppler because I think he shows, right? Yeah. So what he's I don't know if you guys can see this. Oh, this is where he's Dopplering, right along this is the carotid artery, all right? So we identify that we're lateral enough, okay? And now we're gonna take a Bovi cautery and we're gonna open the dura, all right? And that's going to open into where the pituitary gland would be, or in this case, our adenoma, all right? And so this is the Bovi, it's monopolar cautery. I'll move this. All right, and that's a small retractable knife. Oh, oops. Pictures of my kid. Oops.
Dr. D'Amico, they're asking why you decided to do it endonasally.
You know, it's pretty much always done endonasally for the past, 50 plus years. And the reason is that to do a craniotomy, you have to retract normal brain. This is a normal brain, normal healthy brain, right? You have to put pressure on that. And this is a incisionless access point that takes you straight to the tumor without bypassing any critical structures, right? If you come subfrontal, you have to bypass the carotid artery, the optic nerves, the anterior choroidal, the PCOM, the MCA branches, you have to split the fissure, and it's just dangerous. And so this is a really truly innovative way to do this. All right, so we're back here. So this is, I'm trying to get that over. This is opening. And so what is that stuff coming out, you think, Ashley, since I can only see you?
Hello. Is it CSF or is it like the arachnoid layer?
No, it's tumor.
Oh, it's tumor. Okay. Tumor.
Yeah, tumor, pituitary adenomas look like snot for the most part. There are some more solid components. And we use a combination of these small little retractor blades and ring curettes, and we kind of scrape them out. And what we don't want to do is irritate the normal gland, all right? So you can see we're going to pull some out, all right? And then we'll get a ring curette back in there and you'll see some of the more solid substance. All right, here you go. Ring curette going in. So that's some more solid tumor, that yellowish kind of discolored stuff. There's a big chunk right there, all right?
Do you have to biopsy
and so
this, Dr. D'Amico?
Yeah, so we send a frozen section and we send permanent pathology. And there you go. And now what we do is circumferentially around the cella, we kind of scoop this out. And the way I like to do it is I always start at the inferior cella because I know that there's just bone behind me. So I'll scrape out the whole bottom part and then I'll go left and right, very gentle touch until you get to the cavernous sinus. And you can feel it for the most part. Sometimes these tumors go in which case you will get very, very brisk venous bleeding, which you just pack off. It's venous bleeding. What you don't want to do is go and reach in and grab the carotid artery because then you will put someone in a very, very life-threatening situation. All right, and so it's very, very gentle touches. And then what happens is because you've debulked the tumor, the pulsation of the brain will actually deliver that tumor that's above it into the cella so you can keep scooping it out. But sometimes what it'll do is it'll leave little nuggets up top. And so you have to really, really diligently go circumferentially around the tumor. This is the last section here at the top where we're scraping around. And so this is a good shot right here. This thing that looks like it's bowing in, that's actually the arachnoid plane between the cella and the pituitary gland and the intracranial space. And so if you rupture that thin membrane, you'll end up with cerebral spinal fluid pouring out through the nose. Right now, you're protected. And so occasionally these tumors will rupture through that. And so as you take out the tumor, you'll get CSF. This case, that plane was completely preserved, which means that we really don't want to rupture it, okay? And so here we are scraping the last bits of tumor out. Last bits tucked under and the kind of blind spots here with the ring curette, all right? And that's it, tumor's out. That's the cella that's the dorsum cella basically coming down into the field. Right, and we're going to put the endoscope in even deeper and look around and make sure that there's no tumor residual. There's nothing left. Now we pack in, this is a substance called Duragen. All right, we pack that in to clog the hole. All right, fill the space a little bit, tuck that in, and then we'll glue it with Duraseal, which is, you know, we show that we're basically a commercial for Duraseal at this point. We use it in every single case. All right, and that's a watertight closure there because we did not have a CSF leak. All right, now we just put in these packings, these nasal packings, and that's it. This is the post-op film here. You can see it went from this, right? Complete resection. The optic chiasm is completely decompressed now, right? This is cerebral spinal fluid here. And the dorsum cella has come down completely, and we've kind of restructured the whole, you know, cella, all right? So tumor's totally out, which is great. So that, in these settings, in a benign pituitary adenoma, that is a surgical cure, right? That person doesn't have to worry about this anymore, which is, you know, why it remains one of the really, really, really rewarding cases that we do. Recovery is about 2 days in the hospital. Now, if you get a CSF leak, things are a little bit different. Typically what happens is we pack fat. We take fat from your belly, like, you know, not omentum, but regular fat. We stuff it in there and we glue everything shut. We can also elevate something called a nasal septal flap, which is mucosa that's vascularized that we put over there and we lock into place. Mucosa will grow back in like a day. It's very, very fast to grow back. What else? And then sometimes we have to put in a spinal drain to divert cerebral spinal fluid to allow that to heal, right? Pituitary gland can get damaged. Does anyone know what it's called when someone, after a pituitary surgery, their urine output goes up to, you know, extreme amounts. They're extremely thirsty and their sodium levels rise to dangerous amounts. Does anyone know what that is? SIADH, yeah, exactly. It's actually DI. SIADH is the opposite. So diabetes insipidus is when you're just peeing out basically free water. Your sodium levels rise to a level that can actually kill you, cause it not just an arrhythmia, but seizures, okay? And that can cause from stimulation of the gland, okay? Pituitary insufficiency happens more with the craniopharyngioma. It's more when you're really interfering with the gland, in which case someone needs like a total hormone replacement. It's a very dangerous thing as well. And so that's a pituitary surgery. I love them. These tumors get much bigger than that. And they also sometimes can be much smaller than that. So in Cushing's disease, a microadenoma that secretes cortisol is an extremely dangerous thing and it needs to be resected. And they're micro. So you have to find them within the normal gland. And so you have to disrupt normal gland, which means you're causing problems. And then if you don't get the whole tumor out, they're left with symptoms. And so, you know, those are very, very difficult, you know, tumors to treat. And I would actually recommend, I don't know if any of you watched the Miami Brain Tumor Global Symposium. It's a great initiative that the University of Miami did. They have a great Cushing's talk that I would recommend you guys go and check out.